half the nursing homes in America will tell you on official government paperwork that they are losing money. And yet, private equity firms, real estate trusts, and family offices are lining up to buy them at record prices in cash. In 2025, a single 160-bed nursing home in Colorado sold for $52 million. That's over $300,000 per bed for a business that, on paper, barely breaks even. So here's the question I want you to hold on to for the next 15 minutes. If nursing homes are such terrible businesses, why is everybody buying them? Because I promise you, the answer is not they're all secretly rich. The answer is much stranger than that. And by the end of this video, you're going to understand something about American healthcare that most people who work inside it don't fully understand either. Let's start by buying one. You're an investor. You've got some capital. You've read the demographic headlines, and you want a piece of the aging boomer trade. So you go shopping. There are around 15,000 Medicare and Medicaid certified nursing homes in the United States, housing about 1.2 to 1.3 million residents on any given day. The average facility runs about 107 to 109 beds. Let's say you find one. Call it Maple Grove. 100 beds in a mid-sized town, a little tired but structurally fine. The average private equity acquisition of a 100-bed facility runs about $10 million. Industry data puts the going rate around $95,000 per bed, with cap rates around 12%, high, which tells you investors demand a big return because they see big risk. Fine. $10 million. You own a nursing home. Now, how do you actually make money? Here's where almost everyone's mental model breaks. You probably assume a nursing home charges residents rent, the way an apartment building does. It does not. A nursing home has 3 completely different customers paying 3 completely different prices for the exact same bed. And understanding that one fact explains nearly everything. Customer number 1, Medicaid. Medicaid pays for roughly 63% of nursing home residents. These are your long-stay residents, people who will live in your building for an average of about 3 years, who have spent down their savings to poverty, and whose care is now paid for by the state. Medicaid sets the price. You don't negotiate. And here's the killer. A federal analysis found Medicaid payment rates cover only about 82 cents for every dollar of reported cost of caring for those residents. You are losing money on roughly 2 out of every 3 people in your building. That sounds like a death sentence. So let's meet customer number 2. Customer number 2, Medicare. Medicare covers only about 13% of residents. But these are a completely different animal. These are short-stay rehab patients. Grandma broke her hip, she had surgery, the hospital discharged her, and she needs 3 weeks of physical therapy before she can go home. The average short stay is about 25 days. Medicare pays for up to 100 days, and it pays a lot, hundreds of dollars a day, several times the Medicaid rate. How much better is it? The Medicare Payment Advisory Commission, MedPAC, the nonpartisan body that advises Congress, tracks this every year. In 2024, the fee-for-service Medicare margin for freestanding skilled nursing facilities was 24.4%. 24.4%. And they project it will hit about 25% in 2026. 2023 was the 24th consecutive year that margin exceeded 10%. For for-profit facilities specifically, it was 27.2% versus 10.8% for nonprofits. Sit with that. On the Medicare book of business, a nursing home is running margins that would make a software company blush. And customer number 3, private pay and Medicare Advantage, the remaining 23% or so. The national average private pay cost for a shared room in 2026 is about $327 a day, roughly $119,000 a year. Real money, but a shrinking slice, because Medicare Advantage plans negotiate hard and authorize fewer days. So now look at what you've actually bought. You did not buy a nursing home. You bought a portfolio of 100 beds, where some beds lose money every single day and other beds print money every single day. And the entire economics of your business, the whole thing, comes down to one number. The industry calls payer mix. Which brings us to the first thing that surprised me when I dug into this. Because if you're an operator, you now have an incredibly powerful and slightly disturbing incentive. Chase the Medicare bed. Build relationships with hospital discharge planners. Market your rehab gym. Hire therapists, because every Medicare patient you convert from a Medicaid bed is worth multiples in revenue for the same square footage. The industry has a polite phrase for managing this: census management, and it is the single most important skill in nursing home operations. Okay, so you optimize your mix. Now let's talk about where the money goes, because the cost side is where operators genuinely, legitimately bleed. Labor is the beast. Direct care spending runs about 66% of net revenues. Nursing homes employ about 1.5 million people nationally, and the workforce has been in crisis for years. Nursing homes shed 210,000 jobs between February 2020 and December 2022, the worst job loss of any healthcare sector. And when you can't hire, you rent. Agency staffing. The share of nursing hours covered by agency staff jumped roughly 3.5-fold, from 3.2% to 11%. And by 2021, agency labor cost about 75% more per hour than a facility's own employees. That is a margin-destroying number. If a fifth of your nursing hours are coming from a staffing agency at nearly double the rate, you are not running a care business anymore. You are running a very expensive temp agency with beds. Turnover makes it worse. CNA turnover, your frontline caregivers, ran over 42% in 2025, and that was an improvement. Every departure costs you recruitment, training, and quality. And underneath all of it sits occupancy. Nursing homes have enormous fixed costs: the building, the kitchen, the minimum nurse coverage you must staff, whether you have 60 residents or 95. Occupancy averaged around 80% before the pandemic, collapsed to 67% in 2021, and had clawed back to about 77% by mid-2024, with forecasts putting it around 80 to 81% for 2026. Empty beds are pure loss. The break-even is brutally sensitive. Add it up and you get the number the industry puts on billboards. In 2023, the all-payer total margin for skilled nursing facilities, everything, all payers, all lines of business, was 0.4%, 0.4%. And in 2019, 46.6% of nursing homes reported outright accounting losses, with a mean profit margin of 0.13%. So there it is. The industry story checks out. Nursing homes are barely surviving. Medicaid is starving them. Labor is eating them alive, and they need more money. Except for one number that ruins the whole story. If nearly half of these businesses lose money every year, why is the annual exit rate, the rate at which nursing homes actually close, only about 1%? Think about that. Imagine an industry where half the firms report losses year after year after year for 2 decades, and almost nobody leaves. That's not an industry in distress. That's an industry with a secret. And in 2024, 2 economists found it. Ashvin Gandhi at UCLA and Andrew Olensky at Lehigh had exactly this puzzle. There is this flood of private equity investment into this industry, Olensky said. Lots of money pouring in, and not at discounted prices. So they went looking at Illinois, which, almost uniquely, has required nursing homes to disclose their transactions with related parties for 2 decades. A related party is a company owned by the same people who own the nursing home. And here's how the trick works. Your nursing home sells its own building to a real estate company, which you also own. Then it leases the building back, from itself, at a rent you set. You can also spin out a management company you own and hire it, and a therapy company, and a pharmacy, and a staffing agency. Now the nursing home, the entity that files the cost report the government reads, shows enormous expenses: rent, management fees. It looks broke. Meanwhile, the money is sitting in the pocket of the exact same owner, in a company nobody regulates. Olensky's phrase for it: essentially, owners are moving money from their left pocket to their right, and then showing they have no money in their left pocket. The finance world has a term for this: tunneling, and the numbers are staggering. 77% of nursing homes transact with related parties. When a facility started using a related party real estate company, its total reported costs jumped an average of 20%. For related party management services, 25%. Costs went up. Care did not improve. Their headline finding: about 63% of nursing home profits are hidden this way. Meaning, if you only look at what the industry reports, you're seeing about 37% of the picture. The hidden profits are nearly twice as large as the visible ones. And once you account for tunneled profits and assets, the typical investment's implied internal rate of return goes from 4.83%, mediocre, to 13.11%, which is a very good business. So go back to your $10 million nursing home. You weren't buying a care business with a 0.4% margin. You were buying an operating company that runs at break even, wrapped around a real estate company, a management company, and a services company that capture the actual return. The nursing home is the front end. The value is in the stack behind it. And this reframes everything else. A separate study using 2019 cost reports found that when you strip out disallowed costs and non-cash depreciation, the average margin was closer to 9%, with about $11 billion flowing to related parties and about $11 billion in profit across the industry. Now, the industry pushes back on this, and I want to be fair, because their objection isn't crazy. A trade association responded to the research by saying they don't believe tunneling is common practice, and that because long-term care is chronically underfunded, ancillary services and related parties sometimes help keep facilities afloat. And there's a real point in there. A lot of these arrangements are legal. Some are ordinary corporate structure, and Medicaid genuinely does pay less than cost. Both things can be true. Medicaid underpays, and the reported losses are, at minimum, wildly incomplete. But here's where it stops being an accounting story and starts being a human one. Because the same structures that hide profits also strip the operating company. When researchers Atul Gupta, Sabrina Howell, Konstantin Yanilis, and Abhinav Gupta studied private equity acquisitions of nursing homes using patient-level Medicare data, they found what happens after a buyout. Management fees rise 7.7%. Lease payments rise 75%. Interest payments rise about 325%. Cash on hand falls about 38%. The building gets more expensive. The debt gets heavier. The cash gets pulled out. And the nursing home, the actual place where actual people live, has less. Their finding, published in the Review of Financial Studies, private equity ownership increased resident mortality by about 11%. Roughly 20,000 people who likely would not have died otherwise. Antipsychotic prescriptions, drugs discouraged in the elderly, rose 50%. Nurse availability fell, and Medicare spending per patient went up 11%, billed to taxpayers. The economics didn't just extract money, they extracted staff. And staff is the thing that keeps people alive, which sets up the last act of this story, and it's happening right now. In 2024, the Biden administration finalized the first ever federal minimum staffing standard, 3.48 total nursing hours per resident per day, with a registered nurse on site 24/7. University of Pennsylvania researchers estimated it could prevent roughly 13,000 deaths a year. The industry fought it as an unfunded mandate that would close rural facilities. The industry won, comprehensively. The One Big Beautiful Bill Act, signed July 2025, blocked the staffing rule until 2034. Federal courts vacated it. In December 2025, CMS issued a rule repealing it outright, effective February 2nd, 2026. The federal staffing floor reverted to the old standard, an RN for 8 consecutive hours a day. And in the same bill, roughly $911 billion in Medicaid spending reductions. So follow the incentives one more time. The Medicaid side, which is 2/3 of your residents, is about to get tighter. The staffing mandate that would have raised your costs is dead. The Medicare side is still running 25% margins. So much so that MedPAC is now telling Congress to cut skilled nursing payment rates. And the population aged 80 and over is set to grow by about 8 million in the next decade, while facilities keep closing, creating what researchers literally call nursing home deserts, 85% of them rural. Demand exploding, supply shrinking, payments squeezed on the losing side, generous on the winning side. Regulation retreating. If you want to know what nursing homes will look like in 10 years, you don't need to guess. You just need to read the incentives. Because the incentives are the whole story, and they always have been. So, should you buy a nursing home? Honestly, the numbers say yes, and that's exactly the problem. It's a business where the government guarantees your demand, sets your prices, funds 85% of your revenue, and then, through cost reports it can't fully see through, lets you tell it you're broke. But if you're not an investor, if you're just a person who might one day have to put someone you love into one of these buildings, here's the practical version. Ownership matters. Staffing hours matter more than the lobby. And the single most useful question you can ask on a tour is, what percentage of your nursing hours last month came from agency staff? A good administrator knows that number cold. If they don't want to tell you, that's your answer. The bet is the same. The economics behind it are not. If you found this video valuable, leave a like, subscribe, and comment below which business you want me to cover next.